Hi everyone, happy Monday. Thanks for joining us again today. We are introducing the lovely Dr. Tracy Tran, who's a pediatric dentist.
Yes.
And we met her recently and we're so thoroughly excited and thrilled that you are going to be part of our, part of our resources when it comes to lip and tongue tie.
Yeah.
We have some great practitioners here in Southern California. And it's a little bit logistically, our practice is located in the Santa Clarita Valley, and we do a lot of Santa Clarita, Antelope Valley, North LA County, and we've been sending to a wonderful practitioner down in Torrance, which is great, and she's fantastic. It's a little bit tricky logistically for our moms to get down there, our families to get down there. And Dr. Tran, you are fairly local, right in the San Fernando Valley, in Chatsworth, Canoga, Granada Hills.
Yeah.
Granada Hills. So from our location, you're only about 10 minutes away.
Yes.
Which is much more reasonable for our new families that have itty bitties that are really needing to get their tongue and their baby's lips released. So this is a very hot topic.
It is.
Not everybody agrees that it's even something that needs to be done.
Yes.
Let's just start with where do you want to start?
There's a lot of conflicting research out there. It's definitely amongst physicians, pediatricians, ENTs, even pediatric dentists, whether or not this is a procedure that should be done. It's very difficult to diagnose, and a lot of the studies show that maybe 50% of the babies that have this procedure done have success with it. Now, the problem with a lot of the studies is that they don't talk about post-operative exercises, and they also don't talk about whether the procedure was done thoroughly. And so I find those are two really key things to success when doing this. It has to be done deep enough so when we release the tongue, if it doesn't go deep enough, it's not a full release. They still have the same symptoms, and those symptoms are it can be difficulty latching, it can be inefficient latch where they're feeding very frequently, they're getting tired because their muscles are working extra hard to extract the milk or to express the milk, and they end up falling asleep while they're nursing.
We say transfer the milk. As a lactation consultant, we say that they go to the breast frequently, like the baby's on the breast all the time, and they can't transfer that milk well. Therefore, they need to do frequent feedings. They're often irritable, often really gassy, and there's discomfort during the whole feeding session.
Yes. And so when that happens, they end up compensating. They do a lot of up and down movements with the lower jaw.
Chewy. They look chewy when they're at the breast versus
like munching.
Pulley.
Yes. So a lot of the times when the moms come to see me, or actually it's usually both parents, sometimes grandma. But the whole family.
Oh, we just sent somebody. It was both the parents and the grandma. I think saw you recently.
And they were very sweet, but it had a lot to do. I usually explain to them it's like drinking, and I got this from Dr. Bobby Gahary up in Portland, Oregon. He explains it this way too. It's like when you're drinking a milkshake from a straw, if you adjust your lips to pull the milkshake up with the straw, you're using all these lip muscles, your cheek muscles, you're working extra hard to get that milkshake up. If you move that straw between your tongue and the roof of your mouth using the back of your tongue, it's a lot less effort.
Have you ever done that with a milkshake?
I have, yeah.
Wow.
It's a lot easier when the straw's further back. And so it's kind of the same thing when the babies are just using their lips and their cheeks to get the milk out.
And that's also what causes the damage and the pain at the breast, because the nipple needs to be back at the soft palate.
But instead it's towards the front.
And then it gets compressed at the hard palate and the tongue. And then the telltale sign that the baby's not on deep enough is the nipple comes with this lipstick shape or a crease, this blanching crease in one direction or the other. Did you have that with
I don't remember
the first?
the look of it, but I remember the feel.
Yes.
That's really what brought me in.
It's very painful.
It's so painful for the moms. And then they get blistering, they can get bleeding, cracking of the nipples, and it's tough. It's tough for a lot of moms, and if they're not able to get to the point where they're feeding efficiently, you know, it does affect the mothers too. They end up getting some postpartum depression. They feel like they're not connecting with their children.
Yeah. They also get things like plugged ducts, mastitis, lack of sleep, and then the supply, because the baby's not transferring the milk well. By the 4-month mark, even if the baby is appears to be transferring well, right? If the mother has an oversupply, this is the thing. They have this oversupply, a forceful letdown, so the baby kind of passively can get all of this milk, but is still not stimulating enough.
Exactly.
So by the 3-4 month mark, the supply tanks, and all of a sudden, 10 to 12 weeks, all of a sudden, oh my gosh, my supply is gone. And it really was probably all along going to happen due to this restricted tongue.
And so there's, and that has to do with the demand, like you're talking about. Babies, the demand isn't there, the prolactin isn't getting released from the pituitary gland. You don't get that prolactin release, then there's no milk stimulation. There's no stimulation of milk production. So that's...
How do you assess it? Because a lot of people don't know. They have their baby, most of the time, most people watching are having hospital births. Baby's born in the hospital. Mother is discharged by the OB. Baby is seen by the pediatrician in hospital, and then perhaps starting care with their pediatrician out of the hospital, so there's some incongruent care right there. Mothers and babies are seen by the nurses, some with varying degrees of lactation understanding. So day nurse, night nurse, maybe the lactation consult will come in. It appears as if the baby's latched well, so nobody's really assessing. And a lot of people will say it doesn't exist because they're not seeing that really classic anterior.
Usually when there's a feeding issue, it's a posterior tongue tie. It's not anterior. Anterior, they lift up their tongue, you see this attachment, it's very clear. But
it looks like a little heart, they can't extend. But people say, oh no, but my baby can stick out its tongue, therefore it is not tied, which we know is not true.
It's not true, And the posterior tongue tie is much more difficult to visually assess. When I get in there and I check for it, I get my fingers down in there, I go pretty deep underneath, and I lift the tongue up.
So she gets her fingers in the baby's mouth, lifts up the tongue, and the babies don't tend to like it.
They don't like it, but usually what I'll see is I'll see an attachment that's there that's really difficult to see. It's a little wider. It's not like a stringy looking attachment.
It's more thick.
It's thicker, and then it's also a lot shorter. So in order for me to lift the tongue up, it takes a lot of effort. And trying to lift up, essentially, I'm getting the fingers underneath the tongue to lift up way in the back to see if I can lift up the back part of that
So
tongue.
you want to lift up kind of the middle to the back of the tongue. So tell me if this is accurate. What I do tell my family sometimes is when the baby cries, if they make a bowl with their tongue, that is an indicator of a posterior tie.
Absolutely.
Versus the back of the tongue and the middle of the tongue bulging up. They can't lift the middle of the tongue towards the roof of the mouth.
Yes, absolutely. And you actually see when they cry, and I watch them cry, the tongue stays down low to the floor of the mouth. So when it stays really down low to the floor of the mouth, and you see that bowl and that little dimple in it, you can tell. Usually the tongue is meant to protect the airway too. And so if they're not, when they cry really wide and the tongue's not lifting to protect that airway, you can tell they're going to have some issues. And so,
it protects the airway. So that when they cry, if they can't lift the tongue, they're getting in lots of air. Things can get in there because their epiglottis, everything is really open. Interesting.
Saliva, the swallowing. So the tongue performs so many different functions, a lot of voluntary and involuntary issues. So if this does not get solved early on as an infant, and we're already seeing it as an infant, it can present as other issues later on in life.
Which we were talking with Kelly, who's here with her 6-year-old, wasn't addressed, didn't nurse well, correct?
No, I ended up pumping for a year.
Because she wasn't latching well. She was not latching. Painful, right, so then, as it's presenting now with a 6-year-old, is sleep apnea, loud sleeping, snoring.
Night terrors, which it really
night terrors.
So it has a lot to do, and what I was explaining to Kelly, it has a lot to do with how strong their muscles are in the back or how flaccid they are. in the airway. And so the tongue is a part of that. The tongue is the anterior or the front part of the pharynx, the oral pharynx. So if the back part of the tongue is not strong, it doesn't have good tone to it, when they're laying on their back, they can certainly, as they're breathing, it can pull the soft tissue in.
Yeah.
And it collapses on itself.
Wow.
And then you get, that's how you get the snoring noise. It does it with a soft palate as well.
Right.
So there's different, so
yeah.
when they're older, we have them do myofunctional therapy, some exercises that help to strengthen up the tongue. And if they're tongue-tied, we do the surgical release of it, and that improves their sleep. I've done it for several kids.
So you also do older children.
I do older children.
So interesting thing about when you're on your back. So with a newborn, when we in our practice are working on breastfeeding issues, a lot of people are still doing this sitting up with a boppy underneath them or some kind of breastfeeding pillow, cross cradle, leaning forward, right?
Yeah.
And so then the baby is somewhat on their back.
Okay. Yeah.
So then they come into my care or come back into my care if they've had this is a typical hospital position. Like this is how you're taught to breastfeed when the baby's born at the hospital, right? So then I say, get rid of the pillow, Nancy Moorbacher technique, get rid of the pillow, have the mom somewhat reclined, have the baby lay flat, because we know that when they're on their back or on their side, it tightens their jaw. But what it's also doing is what you just said.
The tongue's falling back a little bit.
The tongue is falling back and they can't get on deeply. So we just switch their position to where their wrists, their ribs, their knees, and their feet, right? Basically tummy time.
Yeah.
Where the baby's down on mom so that it's more relaxed and can lift up their chin into a sniffing position, right?
Yes.
But that goes along with what you were just saying, because when they're on their back, they don't have good tone.
Yes.
So it's causing
the tongue's falling back.
And then they can't get on deeply. So this, we think by controlling the baby better with this pillow, cross cradle, holding the breast and ramming the baby on, that is just addressing the look of the latch, actually. It's actually having an adverse effect on the deep latch.
Yeah.
So you have to adjust that baby into a reclined position where they're down.
So the baby's essentially laying on top of the mom.
Yes.
Tummy down.
Tummy down.
Okay.
And crossed cradle or on the side or whichever position, but the baby is stabilized with the ribs, the wrists and the ribs. And so when a baby's on their tummy, they relax.
Yeah.
It calms the central nervous system, right?
Yeah.
And then they have the ability to reach into a sniffing position and get on, so they can get on deeper.
Yeah, which is interesting that you call it the sniff position, right? Because when I think about when people are put to sleep in general anesthesia, when you can't, they teach us this, when you cannot see the airway, you have to move the head into a sniffing position to open up the airway so you can see it better.
Right. It's the same thing with when we have to resuscitate. If we have to breathe for a baby, you have to get them into a sniffing to open the airway.
Which also kind of explains why people who don't have good airway in general tend to have poor posture. They tend to bring their head forward, shoulders are forward. They have that sort of posture.
They're intuitively trying to open their airway.
Yes.
So babies, so this tongue release is it's hard to assess if it's not a really classic anterior, right?
If you don't visually see it in the classic anterior type, then yes, that's a lot harder to assess.
And so many of our providers will, if they see the anterior, they'll say, oh, I can clip that easily. Oh, just go to so-and-so or so-and-so and we'll clip that anterior. And they, 9 times out of 10, I would say, unless you're going to a specialist like Dr. Tran or our other providers that we recommend, they're not getting it deep enough, and it's not solving the problem.
It's not solving the problem. And then when it doesn't solve the problem, the unfortunate thing is you know, the moms say it didn't work, and then they tell their pediatricians who say, I've had moms that did it and it didn't work for their baby, and then you get a lot of just disappointment and and disbelief in it too. People just start to think it doesn't work. People say it works, it doesn't work. But it's because a lot of, and I will admit, amongst all of the professions in pediatric dentistry, there's a lot of pediatric dentists who who are starting to do it.
Mm-hmm.
But again, if they're not really well versed in how to diagnose and how to assess feeding, then there's no way that they'll be able to do it
Right.
properly either. And even though their intentions are really good, I try to advocate really learning everything around breastfeeding before you do the actual procedure. So,
Why do you think, and this is a question we get asked all the time,
yeah.
why does suddenly every baby have a tongue and a lip tie? And then we'll address the lip in a minute, but
Yeah.
that's the big question we have. And I can tell you, we assess at birth. We do a tongue assessment at birth. We do it at the 1-day visit when we come to the home.
Mhm.
We do it at each visit subsequently in the postpartum period, because I'm a lactation consultant as
Yes.
well.
Yes, yes.
And I can say that at least 50% of our babies have
Tongue tie.
some kind of tie.
Well, you know, it used to be, you probably know this, back in, what was it, the early 1900s?
Yeah.
Even
Yeah.
the 1800s?
Mhm.
Your job as a midwife, it was normal. You'd have a long pinky nail and you just go in and clip it.
And release it. The midwives would
was-
do it with their long pinky nail.
That was standard of care. That was very normal
Mhm.
back in the 1800s, early 1900s. Then you get to the 1920s or the
Right,
70s?
1920s.
1920s when formula came about, bottles came
Oh,
about, or is it
20s.
the 70s?
I'm not sure.
I don't know for sure, but as soon as formula and bottle feeding came
Yes.
about, it was like, oh, if I have this issue, it's not a big deal. I can give my baby a bottle.
Right.
So it kind of just went away, that practice of assessing tongue ties.
And then we
just-
started hearing things like, oh, I just wasn't able to breastfeed, or I never made enough milk, but my
Yeah.
mother never made enough milk either.
And so we're
Right?
seeing
So
historical.
we just don't make enough milk in my family,
Yeah.
or it hurt too much and I
Yeah.
just stopped. But the number one thing is, women just thought they didn't make enough milk.
Yeah.
And that is a very rare condition. We've seen it a few times. I can count on one hand how many actual cases of
Really?
it's called hypoplasia.
Yeah.
Women that just don't have the glandular
Yeah.
tissue to
That
make
makes
milk.
sense.
That is
That
a
makes
condition
sense.
that exists, but it's rare.
Yeah, it's very rare.
Not all of the women that we're seeing in our culture right now that, oh, my mom didn't make milk and I don't make milk, and
And so it's a normal thing. They
It's a
think
normal
it's
thing.
normal. There's no way to fix it. But when you go back to that supply and demand, if it
Mhm.
doesn't exist, then you're not going to have the
Right.
supply when there's no demand.
so now we're talking about it a lot more. Now we're saying, wait a
Yes.
minute, this is a thing, and that
Yeah.
it isn't suddenly every baby has it. It's
Yeah.
that babies had it, midwives addressed it, then midwives stopped attending births,
Right.
and then bottles were introduced, or we had, or babies didn't live.
Failure
Because
to thrive.
failure to thrive.
That's it. That happens.
That happened back before we had bottles and formula, right? Babies didn't, even if there was a wet nurse available,
Yes.
babies didn't thrive and
Yeah.
they died.
Because,
And then, because they couldn't get food.
Yeah.
And then bottles and then formula, and now we're saying, wait a minute, there is a condition here. Let's address it.
yes. Yes. So medical technology, modern technology is really advanced and it's great and it's helped a lot of these babies to live and carry on in life,
Mhm.
but they still end up with the same issues. They can have feeding issues still as they grow up, feeding and swallowing, speech issues,
Mhm.
breathing issues, and a lot of the parents notice this, and a lot of moms are looking for answers. They always are, and unfortunately there aren't a lot of doctors out there who quite understand the functional aspect of feeding and swallowing and breathing and
Mhm.
speaking as well, articulation.
So pediatric, you're a pediatric dentist. So as a
Yes.
pediatric dentist, you perform this procedure. There's
Yes.
certain pediatric ENTs that will do the procedure.
Yes.
Some pediatricians will do the
Yeah.
procedure.
Mhm.
And talk about the procedure a little bit.
So the procedure is actually very easy. I numb my patients. I provide a couple drops of local anesthetic because I want them to be comfortable.
So you have this brand new baby, and you
Yes.
do on a Q-tip, drop it in their
Just
mouth.
local anesthetic with the Q-tip just for some topical.
Mhm.
I keep it very minimal because they are really small babies. their livers aren't fully developed. They can't process the anesthetic the same. So I'm very careful with how much I give. And I make sure that they have their vitamin K shots first, because
that's interesting.
when they're really little, they don't have the ability to clot their blood as easily. Their vitamin K is really low. So
Yes.
when you do these procedures, they can have bleeding, and you want to make sure that
They don't have vitamin K deficiency disease.
Exactly.
But those that don't have the disease
Yes.
won't have a problem clotting,
Yes.
even if they didn't get the shot.
Yes.
So that's
hard to assess, though.
hard, right?
Hard to
We
assess,
won't know,
so.
and the mouth bleeds a lot as it is.
It's a bloody business.
It's
It
a bloody
is,
business.
it is.
So I'm
It's a
not
little
saying that they
traumatic.
shouldn't have the vitamin K shot. But
What's great though is I use a laser, and with the laser there is not a lot of bleeding, so that
because it's cauterizing as you're doing it.
Yes. There's different ways you can do it. You can do it with scissors. You can do it with a diode laser, and you can do it with a CO2 laser. So
Okay,
those things are different.
they are different. So
They
two
are.
different types: a CO2 laser and a what kind of laser? Diode laser, and then a scissor.
Yes.
And everybody in my practice, people really want the laser, and partly I think because the parents feel better with a laser.
Yes.
Is one type of tool better than the other?
Yes, I would say so.
Okay.
So in the practice that I'm at in Granada Hills, I actually practice at several different offices.
Mhm. We're trying to get her to come here like once a month.
Yeah, I'm in Granada
We haven't done
Hills,
it
and I'm in Redondo Beach. So the office that I'm at in Granada Hills, I have a diode laser, which the way that it works is it's a laser beam that goes through the tip of the laser, and it generates heat at the tip of the laser, and essentially the cutting that happens is done with the heat. So
Okay.
you can do that with electrocautery too. It's the same thing. It cuts, and it also cauterizes the tissue at the same time. With that, you do get a little bit more heat dissipation. And sometimes you can get what's called feeding strikes from the babies, because
Oh.
that heat stops the laser.
Oh.
With the CO2 laser, it is a true laser. What lasers are supposed to do is it shoots the light out, and that laser beam actually goes into the cell, and it ablates it. It causes it to burst.
Yeah.
So it targets a specific chromophore, it's called. And so it's the soft tissue and collagen that you have in that attachment.
So it doesn't disperse.
It doesn't disperse the same. You do get a little bit more laser energy that can disperse, and generally you'll get more of that discomfort maybe 3 to 4 hours after the procedure, but then beyond that they're fine. So
Okay.
we do find there's differences in the post-operative.
So then with a scissor, you're not having any of that though. A little bit more bleeding.
You have a lot more bleeding with scissors. A lot more bleeding, but it's all kind of, yeah, I think every tool has their risks and benefits.
Mhm.
And
People think the scissor will hurt more. I think that's a
that's
concept.
it's because when you look at it, it's bleeding more,
Yeah.
so it looks like it would hurt more. But I think when it comes to all three, it's all kind of the same
They each have their drawbacks in terms of
in benefits. Yes.
yeah,
Yes.
pluses and minuses. The scissor is going to have more bleeding.
Mm-hmm.
The diode is going to have more dispersed heat, so maybe more nursing strike
Yeah.
the next day, which I definitely see.
Yes.
I definitely see that
Yes.
in my clients.
Yes.
And then the CO2, less heat disbursement,
Yeah.
maybe some pain 4 hours later.
Yes.
Okay.
And then the healing, they say, is better with CO2. They say healing, there's more post-operative pain with the scissors. There's no research to support any of this quite yet, but I know that it's being developed.
So when someone is looking for someone to do the release, is the
Yeah.
question, I would think, I'm going to go to you and I want you to use the tool that you are the most comfortable using.
Absolutely.
Right?
Yeah.
I don't want you
Yes.
to use a scissor because I'm afraid of the laser if the scissor isn't your forte.
Yes,
It's like I
absolutely.
talk about like OBs, like if you go in and the doctor says, we could put a vacuum on this baby's head or we could put forceps on this baby's head. I'm like, whatever tool you think you are the best at. Don't, right?
Absolutely. At the end of the day, it's not about the tool, it's about the person holding the tool. And so if that provider does not know what they're doing, don't let them do it. And you said you have questions that you have your patients ask the doctors, right? To make sure they are properly vetting them, that they really know what they're doing.
So we are really, I'm so particular about where I send my babies to, because I know I want it done right the first time. I don't want to go back for another release, right?
Yes.
And I want it to work.
Yes.
And a lot of people do it. A lot of people say, we sent somebody in, I didn't send them to this particular provider, but their insurance covered this one particular provider. And I was like, I don't think I want you going there. And they went and they wanted the lip released, and the provider
didn't do it, or
didn't cut the frenulum.
No.
Actually said the baby needed to be put into surgery and have stitches. And I was like, oh my gosh, that's not right. And then when they finally did this release, they didn't release the frenulum. And
what did they release?
It wasn't this little thing here. It was like on the side. It wasn't right. It wasn't right.
Oh my God.
So we did a lot of, I asked you a lot of questions. We met several times before we even sent anybody to her, because I was like, oh yeah.
Which is okay.
I'm sure you do this release. So tell me, do you know who so-and-so is and so-and-so is? And oh, you do. Oh, you actually do know quite a bit.
I respect and appreciate that about you, because as much as there are doctors that may or may not know about posterior tongue tie, there are also IBCLCs that may or may not know about posterior tongue tie. And so having a really good team of people, which is why I'm like so grateful for you, it makes my job easier, because I know you know how to assess it properly.
And we do the post-op too. We do the follow-up with these babies, checking that wound and things like that as well.
But you assess what the problem can be first. It can be other reasons, correct?
Yes.
Right? What are some of the other reasons that you see that a baby might not be able to latch properly?
A late preterm. So say we have a 37-weeker, they don't have enough buccal fat, and they're just weak at the breast, right? It could be that they were born a certain way, mom needed some narcotics, and that's, and then the baby's weak at the breast, or the mom is taking narcotics after delivery and the baby's weak at the breast, or the mom's latch, just the technique of the latch isn't very good. Those are all big indicators. Or high levels of bilirubin. This baby is like hyperbilirubinemia, and they're lethargic at the breast, jaundice, and they're high jaundice, right? Or there's Coombs positive, or there's something going on. It's not always the tongue. But once we rule out all those other things, then we're pretty sure, oh yeah, this baby's, and there are certain telltale signs. They're slurpy at the breast. They can't stay on. They're slipping off. They're clicking. They're pouring out, or there's certain telltale signs that
their pattern of sucking isn't a normal pattern of sucking.
Right.
Is that correct? You're looking for a suck, suck, swallow.
Right.
And
versus chewy, 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 chewy. Yeah.
And then you watch the lower jaw, the mandible, just comes up and down, up and down.
Versus pulling.
Yes. So there's all of these things are super important. And if I ever get a parent that comes in to see me and wants this done, I always ask why they came to me, how they heard about me, because I'm not just going to do the release without them teamed up with the proper lactation consultant. If they're not with a highly trained IBCLC that understands posterior tongue tie, there's no way I can guarantee that this is going to work, because I can do the surgery and I can show them the post-operative exercises and stretches, but it's a pattern of swallowing and sucking that the baby already has, and sometimes they have to relearn a new pattern, and they need help with it. So being with the correct IBCLC, someone who's knowledgeable like yourself, that can help the baby through that, is very, very important.
What about working myofascial, like all the body work?
Yes. I find oftentimes they do need that body work.
Because they're tight.
They've compensated already. They've already learned these compensations. In order to actually latch on and to transfer any milk, they have to use what's called their extrinsic tongue muscles. So your tongue has different muscles that go in different directions: horizontal, diagonal, up and down, vertical,
oblique.
And so that tongue should have the ability to move around in so many different directions. Now, when they're posteriorly tied, they can't use those intrinsic muscles because they're restricted. So they end up using these extrinsic tongue muscles in the neck, so you get more tension in the neck. These babies are tight. They need to be released a little bit these muscles need to relax. I have moms do lip exercises or massages to have them massage the lips and relax them before they do the feedings.
Oh, great.
So that the baby's relaxed here and they start to use their tongue afterwards instead. So there's, all of these things are so important.
So what about the lip? What's the lip situation happening? Because lip is still controversial.
It's controversial.
I think if there's a clear lip tie where that frenulum comes around the gingiva, there's a deep divot in the gum line,
right there.
that notching in the gum line. There's always a tongue. Is that correct?
Yes, pretty much.
But not always does the lip need to be released.
Exactly. Yeah, it's very. I will release the lip because we're already doing the procedure, and I let the parents know. I don't know how much doing the lip is going to help. It's usually the tongue that's the problem. So when the baby's latched onto the breast and you see that upper lip is curled under, it's because their tongue is weak, so they're using all their lip muscles.
Oh.
And that's happening.
That's why? I thought
why.
it was because the frenulum is so tight that it can't furl. Or they're tightening their mouth. Oh.
But
that
you'll
makes
find
sense.
sometimes if I don't do the lip and I just do the tongue, that will unfurl.
Oh.
And it'll come out, even if I don't do the lip. Now, my concern as a dentist is when that attachment is really low and they don't have the ability to move their lips and move their tongue to clear it out, they're going to have more
dental
chance
caries.
of dental caries. Yes.
Dental caries in the front. Also, then they have that space between their teeth.
Yes. And not to mention toothbrushing. When the parents get in there, they try to brush. These babies are super fussy because they get these teeth in about around 1 year, 1 to 18 months. And when these teeth are in and they've got that low attachment, they have this tissue that covers their teeth just on the inside. And parents brushing these, it hurts. The toothbrush bristles grab onto this tissue, and the babies don't want the brushing anymore. Then they have this aversion to having anything in their mouth, and so
interesting.
Yeah.
So my son had a really tight lip, and it wrapped around the gingiva, and he told me later, oh yeah, Mom, that used to get stuck in between my teeth.
Yeah. They can't clear out food, and that's why they get the
cavities up in the front.
Yeah. So there's another pediatric dentist friend of mine, Dr. Gamble, and I. She actually, I work with her down in Redondo Beach, and she and I talk about how we have a really, really strong feeling that if these lip ties are addressed early on, we could potentially prevent getting bottle mouth caries in the front and prevent these kids from being put to sleep to have these cavities taken care of. Right. And we don't want that. We don't want to have to put kids to sleep to fix their teeth.
Parents don't want you doing that either.
Yeah, there's so much risk involved. But when they're so little and they've got all the cavities in their front teeth, we don't want them to lose them so soon. That's the only option. So,
is it Dr. Murphy that talks about if you lift the lip? One way we assess for a lip tie is when we lift it, if it blanches across the top.
If it blanches across the top, and if you lift it, if it doesn't cover the nostrils, is how Dr. Gahary assesses it too.
If it doesn't cover the nostrils, I'm only looking to see if I can lift it, if it blanches. Oh, I should try to lift it.
So if you lift and you see that attachment is blanching the gums right there, that's also a sign. Another is you lift it and you can see at the philtrum right here, there's a lot of pulling in the middle. So even if I lift it halfway,
it pulls.
I'll see it pull right there. So that's why you can't actually lift it to cover the nostrils at all. But
interesting. Okay, that's a good assessment. So when you're doing the tongues, you'll look at the lip. And sometimes there is no lip restriction. Yeah. And if you go in, if a mom says, okay, my lactation consultant said that this might be an issue, and they go in for a consult, would you not release one? I would hope you wouldn't release it if you didn't see it. Yeah. But I think a lot of people think that if they go in, it's automatically going to be released.
It's really tough because, I want to help their baby and I want to help them the right way, and all I can do is just educate the parents and let them know, if I were to do this procedure, you need to be with the right person. Otherwise, I won't do it. I do have some moms who are very adamant, and I feel really bad because they're like, please just
Because we want an answer.
Yeah.
We want an answer to our breastfeeding problems, and
Tell them to call Renee.
Yeah.
Yeah, that's what
She
I'll
does
do.
do lactation.
Yeah.
We had a question that came up that's you kind of brought something up that it transitions into. It says, any chance that you'll talk about cavities, ties, and the falsehoods with breast milk and cavities?
Oh, I could talk about the falsehood of breast milk and cavities. Okay, so I'll just address the issue of, like, the dentist will say stop breastfeeding because, you know, if you're laying down and nursing your baby, it's going to cause bottle mouth. Well, if a baby's nursing properly, unrelated to lip and tongue ties, right? This baby's just a normal breastfeeding baby, everything is going fine. Again, the nipple is at the soft palate. So unlike old school bottles, right, where you would leave a bottle in the baby's mouth and it would drip and pool,
Yes.
and cow milk and formula has lactic acid in it
Yes.
and sugar,
Exactly.
and it rots the teeth. Breast milk doesn't have that, and it doesn't drip and pool in the mouth. It's all the way back at the soft palate.
Yes.
So it's not a thing.
We find that you're absolutely right. It's once you start introducing other forms of nutrition besides the breast milk, then those mixed together can create dental cavities. So, but you're right. I mean, it's the same thing with, like, when patients ask me, oh, how do you keep your teeth so white? I'm like, when I drink coffee, I put the straw in the back. I don't sit right here at my lips because I don't want the staining to go there.
Right.
I have to go to the back. So if all of it's starting in the back and staying in the back, it's not going to get to your teeth. You'll be fine.
Right.
So
that
like you're saying,
theory that bottle mouth is old school formula fed babies.
those have sugar in it.
Those have sugar in it, and then babies are sleeping with this bottle, and it pools and it rots the teeth.
Yes. And that's like a whole nother issue too, is formula and how much sugar they put in formula too, and how you really need to find a formula that doesn't have any added sugar to it.
Does that Holly formula? Somebody out there might know the answer to that. That's a very popular formula right now from Germany.
Yeah.
And I don't know, it's expensive, and I don't know what the sugar content is, but breastfeeding doesn't cause bottle mouth dental cavities.
Yes. It's more.
But unless we have this, so with a tie, if you're talking about when other nutrition is introduced, is they can't clear.
Yeah. Then the sugar stays there.
Right. But it's not the breast milk that's causing it.
Yeah. It's definitely from things staying up in there. The way that cavities are developed, and I explain this when I just do regular normal dental exams with parents. If it's a new patient exam, I tell them, okay, cavities come from a specific type of bacteria. You're not born with it at all. So if you have bacteria introduced, then they have the ability to get cavities. And all you have to do is feed that bacteria sugar. It eats the sugar, converts it into lactic acid, like you were talking about, and that lactic acid is what plaque is, and that plaque is what sits on the teeth. Now, it needs to sit on the teeth for a certain period of time before it starts to break it down. So, if you're not clearing off that plaque, it's going to continuously eat through the teeth. That acid's going to keep disintegrating the teeth and softening it up. If you get it cleaned off, you're good. But over time, that's how you end up getting the cavities. It doesn't happen so quickly. Now, baby teeth are a lot smaller. The enamel's a lot thinner. They get cavities a lot faster than an adult would.
So I would think that breastfeeding actually has protective factors, given that it's
the immune system.
Yeah.
It balances out the pH in the saliva. The saliva is supposed to help to clear things out. Again, if you're tied here, that lip is being pressed down. There's no saliva staying there. So the saliva's going away. You've got food trapped up in there, and you're not cleaning it. They're going to get cavities much faster. So yeah, I always like to tell parents, if you have cavities, you have that bacteria, try not to share spoons, or I know that we want to lick off their pacifier and give it back to them. Try not
I used
to
to like bird feed my kids sometimes too, like chew up an almond.
And it's totally okay if you don't have a lot of cavities. Like totally okay.
Right. Oh, right.
Yeah.
Okay.
You're basically sharing the bacteria.
Exactly.
Oh, I don't have any cavities.
You don't want to share the bacteria.
Look at you.
And I tell parents, if you have cavities, get them taken care of so you can reduce the bacterial load in your mouth. And that way, lessening the chance of your child acquiring that bacteria. So,
Interesting.
Yeah.
That's great.
So,
the procedure, how quickly? How
it's less than a minute.
Less than a minute.
It's less than a minute.
It's a fast
very
procedure.
fast. If you know what you're doing, it's very fast.
The hardest part is the aftercare.
The
And it's not that it's
exercises.
hard. It's hard for a mom to
It's
do
hard
it.
for the mom to do it.
Emotionally, it's
Because
hard.
you have to go in and you do
It
this, you know, these exercises after, and that's really
Yes.
imperative to making sure that
Maybe just don't like
the release doesn't re-adhere.
Yeah. And
Right, they don't like
I
that.
have them do it with every diaper change.
Yeah.
So they're doing about 6 to 8 times a day.
And they're often,
Yeah.
I tell people when they're doing it, if the baby's crying, take that opportunity to do the
while
exercise
they're
because they're
crying.
already
Yeah.
crying. Like you don't have to calm them down and soothe them
Exactly.
after their diaper
Exactly.
change and then do it. If they're
Yeah.
crying and it's time for it, get in there and do
Or
it.
do it before. I think you told me to do it before breastfeeding because then the breastfeeding itself would calm.
And then the milk
And it would,
actually helps
heal
Yeah.
it.
heal the wound. Mm-hmm.
Yeah.
So she'd
It
get
does.
all worked up and
Yeah,
angry,
it
and then they
does.
breastfed her.
I actually like for moms to bring in the office in Redondo Beach, the other doctor that I work with, Dr. Gamble, she has the moms bring a little container with breast milk
Yes.
in it so that before the procedure and after she'll put it on to help
Help with the healing.
help with the healing.
It's good for diaper rashes too.
Yeah. It is.
So, and it can be done. Do you do all ages?
I do all ages.
So not everyone does all ages. Like Dr. Murphy, I think just
He
does
just does
babies.
Yes.
Gahiri?
I think he'll do some of the older children.
Mhm.
That I personally don't know.
Yeah,
I know
just
he
curious.
does a lot of babies.
Yeah.
Dr. Zaghi, for instance, he's in Westwood. He does the functional frenuloplasties for the older kids that have sleep breathing issues.
So what does that mean?
So
Suturing and
it's more involved.
general anesthesia?
Sometimes for some of the younger
Yeah.
kids, yeah. If they're about 1.5 to 3 years old.
So I guess
Sometimes
the
it involves
short,
that.
so it can be done from, we've had babies literally be born and leave the birth center and go straight
Yeah.
to have the
Mine
release
was
when they're
3 days old.
You were 3 days. So sometimes we've had releases done within the first 6 hours of life because they're so restricted.
Yeah.
And we could get it done right away. But from birth until adulthood.
Until adulthood, yes, because they present with different symptoms later on.
Yeah.
Because if they're functioning irregularly, well, so normal function, normal swallow is you should be able to, and I have all kids and adults do this. You should be able to